Okay, so good afternoon and a warm welcome to all the dignitaries present here. I'm Sreushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event hosted by the National Neonatology Forum, Gujarat. And the focus of today's session is lessons from expert neonatal uh, cholestasis nightmare. So, without any much delay, now I would like to hand over this session to Dr. Kunal sir. Over to you, sir. You can proceed with the talk.
Thank you so much, Shriyashi. So, with great pleasure, we are continuing with our Neonatal Pathshala series. So, today we have a very interesting topic on neonatal cholestasis, which actually is a nightmare for all of us because it is very difficult to diagnose and also to treat. So, for that, we have a great expert, Dr. Vipul, with us. Thank you so much, Dr. Vipul, for joining Neonatal Pathshala series on such a short notice. So, thank you once again. For further proceedings, I would request Dr. Vishal Goel, who is our project coordinator. Over to you, Dr. Vishal.
Thank you so much, Kunal. And again, thank you, Dr. Vipul Gautam. I think we yesterday called him and he ready for this session. And actually, Dr. Kunal rightly said that the college stress is a nightmare. And when I think even in the OPD, like parents come with the jaundice, like in our PGs, we remember that when there's a prolonged, we always thought about the biliary atresia, and we always, think about the severe cause. But before that, I think lots of cause has to be ruled out, and to rule out that cause, I think we do have a we need to take a help of the gastroenterologist, and now we have a lots of pediatric gastroenterologists in Gujarat, but in the in before 15 years it is difficult to get the direction, and to sort out this kind of query we invite Dr. Vipul Gautam over here. He is one of the consultant and pediatric hematology and liver transplant consultant at Max Hospital, New Delhi. He did the MD pediatric followed by DM in pediatric hepatology. I think few of the DMs, if I talk about the gastroenterology in pediatric, is one of them. He also did the fellowship in transplant critical care Tokyo. He has a multiple international publications, more than 18 in number. Also wrote two book chapters, e-learning module. He awarded like multiple international award like Young Investigator Award in Aspen 2022, Denmark 2024, Milan in Italy, also in Malaysia. Also did the lots of fellowship and also like travel grant for APASL 2025 Beijing. So I welcome Dr. Vipul Gautam, and I think you can share your screen so we can start the session. Welcome, sir.
Is it visible?
Yes, yes.
Okay, just a second. Okay. Okay, thank you for giving me the opportunity to speak on this prestigious platform. And am I audible?
Yes, yes, yes. Please go ahead.
So the topic is neonatal cholestasis. It's a nightmare. Definitely, it's a nightmare. And I'll try to simplify the approach and management. So I'm just jumping to the contents. I'll be presenting my talk under the following heads: introduction, unique aspects of neonatal cholestasis, the etiological spectrum, specific etiologies, not only biliary atresia, there are a lot more, diagnostic steps, the transplant and outcomes, and treatable causes of neonatal cholestasis. Because whenever we are dealing with NCS, we should know which diseases can be cured without any surgical intervention, and the algorithmic approach. So, what is neonatal cholestasis? The first question. So, talking about the consensus guidelines and expert talks, initially it was like if the conjugated part of bilirubin is more than 1 milligram per deciliter and more than 20% total bilirubin. But nowadays, as we are advanced, as we are seeing a lot of patients now, so the definition is now refined. Any child at any age after birth, if has neonate, has bilirubin of more than 1 milligram per deciliter, I mean a direct component, it means it is NCS, and we have to be very careful. Even if a child comes to you at say 3 days of life or 4 days of life and has bilirubin of direct bilirubin of more than 1, then we have to keep the child on radar. maybe the child might develop NCS pretty soon, and we have to be very careful. So anytime in neonatal period, if baby comes to us with direct bilirubin of more than 1, it is significant and it is alarming. And then what is neonatal hepatitis? We commonly talk about biliary atresia versus neonatal hepatitis. We often talk about whether it is atresia or neonatal hepatitis. Then what is this neonatal hepatitis actually is? It is not a diagnosis or any distinguished entity. There is no disease like NCS, neonatal hepatitis I mean. Earlier days, anything which is not biliary atresia was labeled as neonatal hepatitis. Actually, if we talk about this particular term, it is an histological diagnosis. It means there is some inflammation going on, there is giant cell hepatitis, and a particular etiology is not possible to determine from biopsy. Everything that is not atresia was neonatal hepatitis. So if we talk about 1970s, when we knew very less about NCS, almost 65% were biliary atresia, and other were miscellaneous, neonatal hepatitis, and viral. As we came in 2000, the etiological spectrum expanded. Now we have alpha-1 antitrypsin deficiency, metabolic disease, viral, biliary atresia, genetic syndromes, a lot more. And when we entered in 2020, now we can see the expanded spectrum. Atresia constitutes only 40% of the NCS part. Rest are like choledochal cyst, ductal plate malformation, progressive familial intrahepatic cholestasis, Alagille syndrome, metabolic. In metabolic, there is a huge number of diseases which come under this NCS spectrum. There are infections, there are positive interlobular bile ducts, and a lot more. Talking about our NCS cohort from our hospital, we have done almost 500 transplants now, and all of them 150 are neonatal cholestasis with 74% biliary atresia. It is mainly referral bias because the majority of these biliary atresia undergo liver transplant, so they are referred to us. And other are PFIC, metabolic, Alagille, and a lot more. These are the studies from various centers in India and across the globe, and we can see biliary atresia constitutes almost 40 to 50%, and rest are genetic syndromes and a lot more. And in only 10 to 12% cases, we don't identify any particular cause. So talking about the common etiologies of neonatal cholestasis that we encounter in our OPDs and IPDs, the most common being biliary atresia, we all know about it, followed by progressive familial intrahepatic cholestasis. It is a genetic cholestasis syndrome. It is very common. The third one is PILBD, that is paucity of intralobular bile duct. The syndromic diagnosis we know, that is Alagille syndrome, and metabolic liver disease. So these are the common etiologies that we keep in our mind when a patient with NCS present to us in OPD. Talking about biliary atresia, we know biliary atresia is the most common cause of liver transplant in children across the world. In any part of the world, if we talk about liver transplant in children, majority it is because of biliary atresia. So what is biliary atresia? It is progressive fibroinflammatory obliteration of external intrahepatic bile ducts. Let's not go into the technical details. Just simple, the bile duct is obliterated because of fibrous occlusion. The bile ducts are occluded because of fibrous fiber formation. And incidence is quite common, like 1:5,000. Atresia is also of two types: fetal embryonic or postnatal. This fetal embryonic is actually in 10 to 20%, and they present immediately post-perinatal period. Like patient present with a history of, like the child is passing pale colored stool and having jaundice since birth. So this particular history points towards fetal or embryonic origin, and they are often associated with bile acid splenic malformation. I mean biliary atresia splenic malformation. Where apart from biliary atresia, there are a lot more congenital abnormalities are there, and the more common is postnatal type, where biliary atresia develops after the birth. Yeah, you heard it right. Biliary atresia is not congenital. Perinatal events often lead to biliary atresia. The reason for atresia is not yet clear, but there are some factors which play a role and lead to biliary atresia even after the birth. So these kids may present like 2 weeks or 3 weeks after the birth. So how to diagnose biliary atresia? We are living in India. Obviously, we are resource limited, and a lot of the patients are coming from remote areas. So we can simply counsel them to check the urine color and stool color. If the urine is this color, that is dark yellow, we can we can ask the history of diaper staining or any staining of any cloth that the child is using. And we have to see the stool color. If the stool color is pale, it points towards biliary atresia. If it is not pale, it is pigmented, then we have to think for other possibilities, which I'm going to discuss soon. And in other countries, they are screening with the help of blood investigation. What they do, within 60 hours of life, they do a blood test. If the direct bilirubin is more than 1 milligram per deciliter, they consider it significant. And then repeat the test at 2 weeks of life. If it is still high, then means it is neonatal cholestasis and most likely a possibility of biliary atresia. So they work up further. So what's the point of doing this is that even if a patient develops biliary atresia, they pick the case early and they can do Kasai timely. So the Kasai surgery actually saves the patient from early liver transplant. So this is a way to prevent the decompensation in early age. So simple question: if a patient presents to us in OPD and we are suspecting biliary atresia or even not biliary atresia, then what to do? First of all, we have to see the stool color in broad daylight, in sunlight. We have to check it. If it is pale, then we should think of biliary atresia. If it is not pale, then we have to think of something else. Second, we have to see GGT. That is gamma glutamyl transaminase. So basically, if the GGT is high, that means there is obliteration of the bile duct. So it can be biliary atresia, it can be Alagille syndrome, it can be something else. And if it is low, then it points towards genetic intrahepatic cholestasis. So GGT is very important predicting factor. If GGT is high, then we are again considering atresia. Then we jump to USG abdomen. USG abdomen is very important. It shows us the size of gallbladder. There are a lot more signs of biliary atresia like triangular cord sign, like subcapsular flow, biliary atresia, splenic malformation. There are a lot of pointers that point towards biliary atresia. So USG abdomen is very important. After that, to confirm the diagnosis of biliary atresia, we have to always do liver biopsy. I'm saying always do because it is the most accurate and the standard to diagnose atresia. And if we are getting the findings of atresia in liver biopsy, and if the child is less than say 2 to 3 months of age, then we have to subject the child for Kasai surgery. And if we are still not clear, but the child is in the range of Kasai surgery, then we should not leave any benefit. We should not leave any doubt. And we have to jump for cholangiogram. Cholangiogram we can do by percutaneous cholangiogram. That is, we insert a needle in the gallbladder, we inject the dye, and with the help of a C-arm, a fluoroscope, we just check the dye flowing in the intestine, and we can check whether there is biliary atresia or not. So these are the basic steps that we should follow in almost every child under cholestasis. So as I'm telling you, the GGT is very important. Low GGT points towards PFIC spectrum, that is progressive familial intrahepatic cholestasis, or BASD. BASD is bile acid synthetic defects. And high GGT can be seen in biliary atresia, Alagille syndrome, PFIC type 3, neonatal sclerosing cholangitis, or when we are giving total parenteral nutrition to premature kids, or if the child is having sepsis, these patients often have high GGT. So GGT is a very important factor. And one more thing, GGT is we have age-specific protocols for GGT. For different age, the GGT cutoffs are different. So we cannot just project the adult reference range to infants. For example, in a neonate, say 150 GGT is normal, but for an adult it is high. So we have to be careful while predicting GGT and interpreting GGT. I mean. So when we do ultrasound, what to look for? We have to specifically instruct the radiologist that he has to see CBD, gallbladder size, triangular cord sign. That is, it's an echogenic shadow anterior to right portal vein at the hilum. There is increased subcapsular flow. There is prominent hepatic artery, and we should also comment on the splenic malformation if there is another abnormality in the abdomen or chest. And if it is a choledochal cyst, then we will get dilated CBD more than 1.5 millimeter in newborns and more than 3 millimeter in infants. So these are the basic things which we can rule out just by doing a simple ultrasound. The major problem with ultrasound is that kids are often crying, and it's difficult for radiologists to do the scan. So they will tell you that the child is not cooperating and we can't comment on these factors. So what's the best way to do it? Just ask the mother to start breastfeeding. And while doing the breastfeeding, at that particular moment, just do the ultrasound. Doing fasting ultrasound, we won't suggest because actually it compromises our study and it leads to false USG findings. So better to start breastfeeding and then do the ultrasound. Then the question arises, almost every pediatric surgeon asks for HIDA scan before going for surgery. So should we waste time in doing HIDA? The answer is no. HIDA scan is as good as echolic stool. If we are getting a pale colored stool, that is white colored stool, it is equally informative as non-excretory HIDA. Because if the HIDA is showing non-excretory film, that is the bile, the compound is not getting excreted into the intestine, that simply means there is cholestasis. It can be there in biliary atresia or PFIC or Alagille. In any etiology, it will be non-excretory. So if a scan is non-excretory, it does not rule out other etiologies. There can be other things also. So doing HIDA is of no use. Better to do the biopsy, and if still doubtful, then do the cholangiogram. So the role of liver biopsy, it is almost 90% accurate. We have to look for bile duct proliferation, portal expansion, portal and periportal fibrosis, and bile plugs. These are the major things that we have to look when we are interpreting the biopsy from a biliary atresia patient. So here we can see the expanded portal tract. Can you see this portal tract? This is the portal tract, this one. And this is quite expanded, edematous, and there is ductal proliferation at the periphery. These are the ductal proliferation. And also ductal plate malformation is also there, right? So this expanded edematous portal tract points towards biliary atresia. This is the large bile plug, and these are various cholestasis features, the same thing. If we still have doubt after liver biopsy, then we can go for percutaneous cholecystocholangiogram. That's what I just explained. We just insert a needle and we push the dye in the gallbladder. In this photo, we can see the dye from the gallbladder goes in the duodenum and up in the liver. So the right hepatic duct, left hepatic duct, common hepatic duct, common bile duct, everything is patent. So we rule out biliary atresia in this case. On the contrary, in this photo, the dye is just going in the duodenum, but not going up in the CHD and RHD LHD. That means the duct is patent in the distal part, but not in the proximal part. So just don't get confused. The dye is getting into the duodenum, so it is normal. It is not normal. It is also biliary atresia type 2. And in this one, the dye is not going either distally or proximally. So it is a complete atresia. So actually, this is a direct visualization of the biliary tree. And it actually helps in deciding whether to go for Kasai or not. So whenever in doubt, just do the procedure. And what's the role of ERCP and MRCP? I would say there is no role. They're technically difficult. You need to sedate the child, and ERCP is technically not possible in this age group. And also the yield is quite low. So we can't rely on these reports. So basically, if any child who is happy growing, the weight is normal, it's a progressive jaundice, white stools, GGT is high, ultrasound suggestive of atresia, and the biopsy confirms the diagnosis, that means it is atresia. We have to consider Kasai as early as possible. So management of biliary atresia. Now we know we have a child with biliary atresia. Now what to do? Obviously, we have to do Kasai surgery. There are two surgical interventions. Biliary atresia can't be treated with medical management. We all know. There are only two things that we can do. Either we go for Kasai or we go for liver transplant. If a child presents to us within, say, 2 months or 3 months of life, we can offer them Kasai surgery. The earlier we give them the option of Kasai, the better the outcomes are. But in India, sometimes the referral issues, sometimes the patient present late. Only 11% undergo Kasai surgery less than 60 days of life. Rest do the surgery after that. And as we delay the time period, the success rate of Kasai goes down. As we can see in this study, those children who underwent Kasai within 45 days of life had 40% native liver survival at 15 years. Means if a child undergoes Kasai surgery at 1 month of life, the child has 40% chance of survival without liver transplant at 15 years. And if a child undergoes Kasai surgery at 3 months of life, only 10 to 15% survive till 15 years. So if we delay the Kasai surgery, the chance of liver transplant increases. So we have to be very quick. So that's why if you have doubt on Kasai surgery, just get the cholangiogram or biopsy done. Biopsy is quite informative. We should always do the biopsy and subject them to Kasai. So now we have two things. If patient undergoes Kasai surgery, either the Kasai will be successful or unsuccessful. If the Kasai is unsuccessful, that is the surgery was okay, but the Kasai was unsuccessful. That means the child will develop decompensation, the child will develop portal hypertension, there will be variceal bleeding, hepatopulmonary syndrome, and infections. And child will need early transplant within infancy. So if Kasai surgery fails, then child has to undergo transplant within 12 months of life. And if child gets successful surgery, that is, if bilirubin goes less than 1 milligram per deciliter at 3 to 6 months post Kasai, that means it is successful. And then we have two arms. Either the child will develop recurrent cholangitis because now we have done Kasai, so there will be high risk of cholangitis. Irrespective of Kasai surgery, portal hypertension persists, and there can be risk of decompensation. And in another arm, there can be infrequent cholangitis. There is slow portal hypertension. There is no decompensation. So basically, we can delay transplant up to adulthood, depending on the course after Kasai surgery. And we can say if a patient undergoes Kasai within 2 months of life, survival into adulthood without transplant is almost 20 to 30%. That's very quite impressive because on one hand, we are doing transplant at 6 months of age, and in another patient, we are doing transplant in 25 to 30 years of age. The outcomes are drastically different. So that's the value of doing Kasai surgery in the timely manner. So we are talking about biliary atresia, but biliary atresia is not the only modality which we are concerned about. There are a lot more, and with the advent of better diagnostic methodology, we have a lot more diseases now. The most common after Kasai is progressive familial intrahepatic cholestasis. This is actually, there is no anatomical obliteration of bile duct, but the problem is in the hepatocytes. As you can see, this is a hepatocyte and this is a canalicule, bile canalicule. Here we can see there are a lot of transporters like FIC1, BSEP, sterolin, MDR3, MRP2. They transport a lot of components of bile in the bile duct. So when there are defect in these transporters, the bile formation is hampered, and the bile acids, a lot more of the components of bile get accumulated in hepatocyte. And when they accumulate, they develop toxic compounds and they lead to hepatocyte injury. That causes again hepatitis-like features. So this is what PFIC is. It is a group of rare and inherited diseases of hepatocellular origin resulting in disruption of bile formation, as I explained. And one of the important predictors of PFIC is pruritus. These infants often have severe pruritus, itching. They are itching all over the body. They are itching like they are getting excoriation. They are getting bleeding. They are unable to sleep. The pruritus is very severe, affecting their overall development and growth. So nowadays, there are almost 15 types of PFICs that are available and reported in the literature. The most common are PFIC type 2, BSEP, followed by PFIC type 1, the FIC1, PFIC type 3, TJP2, NR1H4, MYO5B. These are the common types of PFICs, and there are a lot more also. But we should be thinking about these modalities if we don't suspect atresia. So if a patient of PFIC presents to us with pruritus, obviously we are not doing any surgery, then what to do? We have to manage it anyhow. So first of all, the first therapy to start in PFIC child is UDCA. Before jumping onto the management, how do we diagnose PFIC? If we do the liver biopsy in PFIC, we'll get giant cell transformation, sometimes bland cholestasis. So it is not actually conclusive. So better to go for, after our initial evaluation that I already explained in the previous slides, we have to go for genetic sequencing. In genetic sequencing, we have to point out the gene that is defected, and then we can subtype the type of PFIC which we are dealing with. So if a child is genetically proven PFIC, presents to us with pruritus, growth failure, the first management is to control the pruritus because it is quite problematic, and you won't be able to see the child in such condition. So we have to immediately start the UDCA with or without cholestyramine. And if there is no response, then we have to start rifampicin. Yes, it is rifampicin, the anti-tubercular drug we use for pruritus. Then we can use naltrexone. We can use ondansetron. And even after using these drugs, the pruritus does not improve. The child is nutritionally not rehabilitated. Then we have to consider surgery. What kind of surgery? Obviously, we won't be jumping the transplant. So first, we will decide whether we can we do diversion surgery. Diversion surgery is what? What happens? The main problem in PFIC is the bile acids. Bile acids are not getting excreted in the bile. So the bile acids are getting accumulated in hepatocytes and are getting into the bloodstream. That is causing the itching and all the problems that PFIC is creating. So we need to get these bile acids out of the circulation. And how can we do that? The one important thing is to obliterate by disrupting enterohepatic circulation, because whatever bile acids are coming in the ileum are getting reabsorbed and are getting back in the circulation, and again the same issue. So our main aim is to stop this enterohepatic circulation so that we can get rid of these bile acids. So for this we can do diversion surgery. In diversion, we just divert the bile from gallbladder to the distal colon or something, so that the intrahepatic circulation gets disrupted, because the bile acids are absorbed in terminal ileum. So we just bypass that part and we interrupt the circulation. So there are various ways of doing it. Like there is external biliary diversion, there is internal biliary diversion, and there is total internal biliary diversion surgery. A lot of kind of surgeries. I'm not going into the details. If anybody wants to know more, just give me a mail. I will share the slides and I will explain it further. So these are the three main types of diversion surgery that we are doing. Just the important thing, only in children who have low GGT and early fibrosis, in these kids we can do diversion surgery. If the fibrosis is advanced, the child has already developed cirrhosis, then we can't do the surgery. In that case, we have to directly go for liver transplant. So only if a child comes to us in timely manner, when the fibrosis is not advanced and the child is stable, then only we consider these surgeries. Otherwise, we have to directly go for liver transplant. So apart from diversion, there is a new drug that has come into the market, that is ASBT or IBAT inhibitor. That is like odevixibat or maralixibat, if somebody of you heard these names. ASBT is apical sodium dependent bile acid transporter and IBAT is ileal bile acid transporter. Basically, it is just like a non-surgical way of doing obliteration of this intrahepatic circulation. What we are doing, we are giving these medicines. These medicines actually block the receptors in terminal ileum and they block the reabsorption of bile acids. That's why they are interrupting the enterohepatic circulation and doing the same way. But what was being done by the diversion surgery. So this is a new drug that is in the market and a lot of trials are going on nowadays. If this drug gets approved and available in the India, it will be a boom and it will help a lot of the kids. But let's wait. I'm not doing the details. Again, if anybody wants to know, please write to me. Now, if we're going for the liver transplant, what's the outcome? The outcome depends on the type of PFIC which we are dealing with. If we are dealing with type 1, there is risk of, graft steatosis and chronic diarrhea. If we are dealing with PFIC type 2, there is risk of auto antibodies develop against anti-BCAP and might lead to rejection. So there are a lot of complications that can happen after the transplant, depending on the type of PFIC for which we are doing it. After PFIC, the another important cause for NCS is Alagille syndrome. Histologically, it is positive interlobular bile ducts. So we all know Alagille syndrome. We have read in Nelson and all what Alagille syndrome is. It's a combination of cholestasis, where there is neonatal cholestasis. There are peculiar facies. The head is broad, deep set eyes, straight nose with bulbous tip, pointed chin, and the triangular facies and prominent ears. There will be peripheral pulmonary artery stenosis in echocardiography. There will be butterfly vertebra in X-ray spine, and then be posterior embryotoxon. So if we are getting these features, then we have to think of Alagille syndrome. One more thing to add, this PFIC, Alagille, these can also have a colic or fluctuating stool. So that's why I always talk about the liver biopsy. If liver biopsy is suggestive of atresia, then consider Kasai. If it is not suggestive of atresia, then we have to think of other possibilities. This is the Gala study group. This is the largest study on Alagille syndrome done till date. Almost 1,200 Alagille syndrome kids were analyzed, and they found that the most common gene affected is JAK1, followed by Notch2. And the 10 and 18-year transplant-free survival in these 1,000 Alagille syndrome patients, these presented with neonatal cholestasis, was only 57 to 41%. That is, the patients of Alagille syndrome who present with NCS, in 50% of the cases, they will require transplant within 18 years. So it's another important cause of liver transplant in NCS. And one more thing, the growth failure in Alagille syndrome is because of genetic disease. So in many of the kids, even after transplant, the growth failure persists. And just like PFIC, Alagille syndrome also has severe pruritus. These kids often have this itching all over the body, just like PFIC. So if a child presents to us with the neonatal cholestasis at 6 months of age with severe pruritus, we have to think of PFIC, Lagel syndrome, and so. Atresia generally does not have pruritus. And the outcomes are as good as any other reason for Kasai, any other reason for NCS. After Lagel syndrome, the metabolic liver disease is also very common. If we talk about the definition, inborn error of metabolism which involve liver either as a hepatomegaly and or hepatic dysfunction in the clinical presentation is metabolic liver disease. As like any other inborn error of metabolism, if these features are there, then we have to consider metabolic. Like if a baby presents to us with neonatal cholestasis and has a history of consanguinity, recurrent abortions, neonatal death in family, unexplained catabolic stress, unexplained vomiting, diarrhea, failure to thrive, short stature, neurological issues, encephalopathy, developmental delay, if the spleen, liver are too big to be explained, if there is specific food aversion to sugar, proteins, and if there is a family history of any X-linked disorder, then we have to consider MLD and we have to work up accordingly. So we will get the pointers. If a child presents to you, you take a thorough history and definitely you will reach to a particular diagnosis. So as I explained, you will often get this organomegaly, the large liver, as compared to any other disease in metabolic, the liver is quite big, going up to the pelvis. Even the spleen is quite big, going up to the umbilicus. There will be unexplained encephalopathy. There will be recurrent episodes of vomiting, failure to thrive. In atresia, the growth is always preserved. However, in metabolic and Lagel, the growth is affected. So they will be very failure to thrive babies. So talking about the treatable cause of NCS, so I have spoken so much about this Kasai surgery, diversion, transplant. So what to do medically? See, there are a lot of NCS causes, specifically atresia, where we can do something apart from liver transplant. Like in atresia, we can just get GGT, ultrasound, and biopsy, and we can diagnose it. And offering them timely Kasai, we can save them from transplant. If we get large CBD, then we just need to resect this cortical system, child will be okay. If there is evidence of galactosemia, for example, on urine routine microscopy, GALT assay, reducing substance is positive in urine, we just keep the child on lactose-free milk and child will be okay. And if we diagnose tyrosinemia based on serum AFP, urine succinyl acetone, then we just give them nitisinone as early as possible, ideally before 1 month of age, and specific diet, then we can save them from transplant. Even many of the kids after prematurity, they develop sepsis, they develop multifactorial related cholestasis. They can be managed with UDCA and other routine things. And if there is endocrine or biosensory defect, we can manage them medically. So if a patient presents to us in early life, we obviously have options to treat them. But if they present late, then maybe many of the options have gone and we have to go for transplant. So it depends on the time of presentation. And also there are a lot of like financial problems also there. For example, for tyrosinemia, nitisinone is quite expensive. So these things have to be considered. So generally, if a patient with NCS presents to us, then we have to check the liver function test. Doing total bilirubin is not enough. We have to get direct component as well. And we have to check the stool color. This is the first and foremost thing. If the patient is having acholic or pale colored stool, then we have to get obviously GGT is the next step, and the ultrasound fasting. It will rule out atresia and cortical cyst. And if it is atresia, then we go for biopsy and Kasai surgery. If it is a pigmented stool, then likely it is not atresia, because pigmented stool means the bile is coming in the lumen. If it is coming in the lumen, it can't be obliterated. So it is not atresia, it is something else. So if it is a well child, maybe it's a prematurely related because TPN often leads to cholestasis. So just giving UDCA works many of the times. Or it can be genetic. If a child is sick, infectious or decompensation, it can be metabolic liver disease or it can be infantile liver failure. So it depends on the kid and the scenario which we are dealing with. This is a study which we present, which I just published this month. In this study of 500 liver transplant patients which we have done, almost 142 were biliary atresia, 40%. And as we can see, only 50% of this surgery, only 50% of these had previous Kasai surgery. So that shows that as compared to 90% of the kids in West, only 50% of the kids in India undergo Kasai surgery, and 50% are still missed. and the outcomes are quite good. It's 90% survival at 10 years of life. It's the same study. I'm skipping this part. So before I start the further discussion, let's discuss some of the common questions that pediatricians often ask to me. In preterm infants, what is the further diagnostic workup should be done immediately or wait for particular corrected days to rule out EHBV? For example, if you get NCS in a preterm infant, what's the right time to evaluate? My answer is better to get the liver biopsy at the corrected gestational age of around 44 weeks. Just wait for the child to be around 44 weeks, because if we do the liver biopsy before this, the changes might not appear in the biopsy and it will be false negative. The other question is, what's the best diagnostic method or approach for biliary atresia diagnosis, and what should be the ideal sequence of steps for investigations? As I explained previously, stool color followed by GGT, followed by ultrasound, followed by liver biopsy, and if liver biopsy is inconclusive, then cholangiogram. So this we can do not only for atresia, for any NCS. And if we rule out biliary atresia at any step, for example, if DGT is low or ultrasound rules out biliary atresia or liver biopsy is not suggestive of biliary atresia, then we have to go for genetic sequencing as per our clinical indication. Genetic sequencing is not always a first line; it is always after clinical judgment. So you diagnose something first, suspect something first, and then ask for the genetic test. So what's the limitation of ultrasound? The most specific finding. Most specific finding is triangular cord sign. That is the echogenic shadow anterior to right portal vein. That's the most important sign. If it is more than 4 millimeter, it is very significant. And if there are gallbladder abnormalities also, then it points towards atresia. But the limitation is operator dependent. Many of the radiologists are not familiar with these kind of kits, and they often miss the findings. So high-dye scan is an added advantage. And what's the role of priming in a high-dye scan with the phenobarbital or so? Which drug is good? Because many of the pediatric surgeons often ask to give phenobarbital 5 days before doing high-dye scan. My answer is there is high-dye scan has a high negative predictive value. That is, if the excretion is there in HIDA, it rules out atresia, but it never rules in biliary atresia. So it is of no significance. So if a patient has pale colored stool, it is as good as non-excretory HIDA. You don't need it. And there is no added advantage of drug augmentation. See, just waiting for 5 days in a baby just to do high-dye scan is of no use, because we know it is of no value and we are wasting time. We are already running out of time for Kasai and we are wasting 5 more days for phenobarbital. Doesn't make any sense. So the liver biopsy should be percutaneous or open. Mostly percutaneous, ultrasound guided we do. And as a part of routine evaluation to avoid unnecessary Kasai. And the limitation is it depends on the expertise of histopathologist. It depends on the center where we are working. And per operative cholangiogram, is it done in all cases? And the answer is yes. Whenever we take a child for Kasai surgery, before doing Kasai, we always do the open cholangiogram because the gallbladder is in front of our eyes. We directly push the dye and we check. And if the gallbladder is normal, if the dye goes in the duodenum and up in the liver, then we might abort the Kasai surgery as well. So how frequent is negative laparotomy? That is, we open the abdomen and we don't do Kasai. In SGPJ, it is 3%, and ILBS it is less than 5%. In our setup, it is almost less than 5%. So better to do liver biopsy and percutaneous cholangiogram to avoid unnecessary laparotomy. This is the same slide I have already showed you. Thank you. And this was the NCS from my side. Please let me know if there's any question. Thank you.
Thank you so much. Thank you so much, people. I think it was very informative session, and I think you answered lots of questions at the end that which were in our mind. But still, we have a lots of delegates. If anyone want to any question, then they can directly unmute, or you can put on the chat box. Then we can ask. The few question like from my side, I think. So there is one slide you show us that biliary atresia baby might have a weight gain. So it is like surprising. Most of time, if you find the biliary atresia, the baby is mostly not gaining weight, thriving. So how frequent is common, because you are looking lots of biliary atresia baby. So what's the percentage for that?
So See, the problem is in India, the major problem is feeding. We often have faulty
Yeah.
feeding. That is the main reason of failure to thrive in these kids. If we get a tracer kid within 3 months of life, if the child is exclusive on breastfeeding, they gain a very good weight. But
Okay.
if we get an infant at 2 months of age on bottle feeding, because see what happens many times, just for the sake of jaundice, they stop. Doctors stop this lactose diet and they start lactose free diet. So and
Okay.
they sometimes they even ask to stop the breastfeeding. So that's the main reason of failure to thrive. And even if a patient does not undergo liver transplant more than 6 months of age, then as a part of disease process, they start losing weight. So
Okay. But yeah,
initially
go
they
ahead.
gain
Sorry.
weight. Initially they gain
Yeah,
weight.
so any baby who present with the pale stool with the weight gain, it's not like that a baby does not have a biliary atresia. But at same time, it is weight gain plus a pigmented stool, then it less likely a baby have a biliary atresia. Am I right?
Yes.
Like that. Okay. So we have one question in chat box like CMV infection can lead to NCS and management in such case.
Yes. See, the old literature says CMV is a common cause of neonatal cholestasis, but what we are now seeing in our practice is it is always a bystander. There are two ways the CMV causes cholestasis. First, is one of the common causes with atresia now. There are a lot of hypotheses that are going on that says that CMV uh, actually helps the atresia to grow. So basically, if there is CMV, the chance of atresia is very high. So they often have atresia on the background of CMV. And very few patients who present with prematurity, seizures, macrocephaly, rash, chororetinitis. In such cases, we can think of CMV infection isolated entity. But many of the times, we have to think of other etiologies.
Yeah, there is another question like post Kasai, how to diagnose cholangitis if child is having recurrent fever but culture normal.
After Kasai, cholangitis is very common. So, if a patient, say, how to diagnose? After the surgery, if the stool color has changed to yellow, if the bilirubin has started falling trend, that means the Kasai surgery is actually working. In this case, if the child develops rising bilirubin, the stool color again becomes white in color. If the child is having evidence of infection in blood investigations despite normal blood culture, then we have to consider giving antibiotics first for cholangitis, because all no, not no, it's not common to have fever after Kasai surgery. But if a patient is having high bilirubin, cholestasis persisting, then we have to consider cholangitis and we have to treat accordingly.
Okay. And there's a one more nice question. Type 2 BA will have a pigmented stool or not?
No, no. Pigmented
No.
stool, because see, in type 2 also the part of the biliary tree is blocked. So the bile cannot come from liver to duodenum.
No, no, I think, okay. So basically the biliary tract is connected with the duodenum but not in the liver. So in
Yeah,
that case, you are not
yeah. Actually,
getting
liver has to deliver. The liver is not there.
yeah, no, no, yeah, I got it. There's a one more question from my side. Like, if you said the TPN induced cholestasis, I think it is very common who are work in the NICU, and specifically because we are getting a lots of IGR baby and abnormal Doppler flow, so we need to put TPN for longer time. So what time you start usually? So when will you think that this baby is right? Because most of the time baby reach to the full feed like after 3 to 4 weeks sometime because of the prolonged abdominal issue. But what time you can start that medication?
See, I would say if a child is on total parenteral nutrition for a long time, for example, more than 1 or 2 weeks, then we can start doing giving UDC at the dose of 10 mg per kg per dose BD, because it will not harm the baby in any way. So we can start it, and it helps in reducing the occurrence of jaundice.
The issue would be the digestion because the baby is still not reached to the full feed. Am I right? So in that case, how will you give that UD live in proper dose? Because if baby is still in the half feed, can we give that one with half of the feed, or that's the issue?
If there's an abdominal issue, if there's a, for example, if we are dealing with necrotizing enterocolitis, something like that, then in such condition, obviously we cannot give anything orally. So in such cases, we have to wait. We can't do anything for this TPN. We have to continue and we have to wait.
Okay, okay. That's
Because
fine.
if a child is allowed like minimal enteral nutrition or something, then we can start giving UDCA. But if the child is absolutely contraindication for enteral feeding, then we can't.
There's one more
Actually,
question.
this this kind of cholestasis is not permanent. Even if you
Yeah,
start later on, then it works. So it's not an
yeah.
urgency.
From our experience, I think we once we reach the full feed when baby gets the weight gain automatically within I think 4 to 6 weeks we just get the normal bilirubin level. So
Yes.
most of time uh, we do not start to prefer this usually because of the indigestion issues, from the vomiting, or they might not tolerate that kind of medication. That's why I asked this question.
Yes.
There's one more question. For screening the CME infection urine or blood, I think so. Urine is probably the most common thing. Am I right? But
Yeah.
how much viral load in urine significant?
See, again, if we are first of all, CMV is present. CMV is present in many of the infants even without cholestasis. So, if we have a neonatal cholestasis, if there is background history of IUGR, say macrocephaly, explained seizure, and if we are clinically suspecting it to be because of CMV, then we have to get it done. And if the CMV is positive in urine or blood, obviously we get PCR. Then it is significant. We have to not we should not go by the urine viral load. We should go by the clinical features. If the child is really clinically neutral cholestasis, which we are clinically suspecting to be because of CMV, then we have to start the treatment if it is positive.
Hmm.
How long do you recommend the treatment, whether 3 months or 6 months?
So minimum actually what we do, we start injection ganciclovir for at least 2 to 4 weeks, and as the viral load comes down, normally the cutoff is like less than 140 or something, which we get in our labs. So if the viral load comes down, then we switch to oral. If the child is able to tolerate the oral valganciclovir.
Total
But
duration?
minimum 6 weeks.
6 weeks, yes.
6 weeks or 6 months.
6 weeks, and then actually we can do one thing. In India, we have either empirical approach where we keep on doing the CMV load, and if it is negative, then we can hold. Because see, giving ganciclovir is also problematic. It leads to cytopenias and all, and also affects the kidneys. So we just don't want to continue it for no reason. So if the CMV is now negative, then we can stop it.
Okay, because our guidelines suggesting 6 months, so that's why we
But
just
we don't.
dilemma.
We don't do.
Okay.
And secondly, just I'm telling you, out of so many kids that we have transplanted here or we are seeing NCS, the CMV as an isolated cause for NCS is not there. It is often because of something else. CMV is actually overdiagnosed. So we should be thinking of something else other than just going for the CMV. Maybe there is something else which is there.
Okay. Any question from audience? Anything from Kunal?
No, it was an excellent session. I think there are no more questions are there. So it was an excellent session, clear, crisp, and you answered many of the questions in your FAQ session. So thank you so much for that. And I think it was an excellent session, and it will be there on our YouTube channel of Gujarat NNF also. So
So, thank you for the
there you take it.
opportunity. Just to add, I would say actually this the problem which I found here is that we are often talking about the CMV virus. See, we have to think because sometimes these random investigations often lead to the delay in the diagnosis, and we just jump the time for Kasai surgery. So
Okay.
before jumping for CMV, just do the side workup if we want. But in this timely manner, we have to evaluate properly for other signs of atresia, because missing atresia is not justified.
Okay. I think thank you so much. I think we can conclude the session. Am I right, Kunal?
Yes.
Yes. Thank you so much, Dr. Vipul. And it was really nice session. And in short notice, you deliver a lot to us, and this means a lot. And I think we will, we are just running this parcel every weekly, so definitely we can ask for another topic in future. So thank you so much.
Thank you. Thank you.
And I think Sreyasi, you can conclude the session.
Thank you, ClearNet, also for the seamless experience. Thank you, Vishal.
Thank you.
Sriyashi, are you there?
Sreyasi.
I think we can.
Yes, sir.
Yeah,
Yes, sir.
please.
So
Please.
thank you, sir. Thank you so much, everyone, for giving us the opportunity to host the session. So, with all your permission, can we end the